So we have come to a very important, prestigious oration now. That is the R.K. Biswas oration. I request Chairperson, Dr. Professor R.N. Sorkar, Professor Udas Ghosh, please come into the dais and start the proceedings. Before you start it, I will request you to felicitate our orator, no less than Professor Alakendu Ghosh, by a medallion before he starts his speech.
Oration, Dr. R.K. Biswas, not Dr. R.K. Biswas oration was instituted by our late professor and very active member of the API, Dr. Professor T.K. Biswas. R.K. Biswas was father. He was a lawyer, and the topic today is what's new in RA. It will be delivered by Professor Alakendu Ghosh. Everybody, he needs no introduction, everybody knows him. He is actually pioneer of rheumatology in West Bengal and has developed a separate department in SSKM, IPGMR. And he is president-elect of the IRA Central, that is India. So without wasting any time, there are very new thing coming up in the rheumatoid arthritis, like epigenetics and the treatment. So I will hand over to Alakendu. Please start the lecture.
Good afternoon. Privileged and honored to be here for this prestigious oration. Respected chairpersons Professor Sorkar and Professor Udas Ghosh and my fellow delegates. So I thought to share with you the happenings in rheumatoid arthritis, because we used to know that rheumatoid arthritis is an inflammatory symmetric polyarthritis, hand joints involvement with rheumatoid factor positivity and anti-CCP positivity with disease-modifying drugs, and when it's not working, and we can plan for biologics. But there is a sea changes in the concept in rheumatoid arthritis at this moment. And first and foremost is the emerging concepts in the pathogenesis. And we know that PTP and 22HLA-DR before the standard genes are there as a background, susceptible gene, but the newer genes like WNT5A signaling pathway has been identified, and there is differential roles in synovial proliferation. There is TNF-alpha polymorphism, matrix metalloproteinase, MMPs have been identified as a potential target as a therapy in management of rheumatoid, which has come up recently 2017. And these newer genes can modulate cellular differentiation, cell proliferation as well as survival, migration and inflammation as well. There are another areas where the basic concepts come up is cytokine, IL-23, IL-17 polymorphism and interferon gamma has been identified, and there is heterozygosity for alpha-1 antitrypsin defined, and deficiency shows positive association with the production of ACPA. And there is another area where lots of literature has coming up, and our group from IPGMER Kolkata Rheumatology Lab also contributed this one. This is in reference to long non-coding RNA. Altered expression of long non-coding RNAs have been reported in RA, and microRNA have important roles in activation, proliferation, differentiation. And out of these microRNAs, 214 and microRNA 7 has been identified in RA, especially with ILD. So these are susceptible epigenetic platform, and our findings has contributed in reference to NEAT1 and MEG3 and MALAT1 increase in peripheral blood mononuclear cells, and it has been identified and which has been accepted in Oxford that dysregulation from our published group, the dysregulation of microRNA 125A, 125B, microRNA 200A is identified in rheumatoid arthritis. Next part is environmental factor. As we know that smoking is one of the very important risk factors for rheumatoid arthritis, and if we look for primary prevention, so this is one of the very important area where if we, in a susceptible host, there is, if we control smoking, there is chance for restriction for development of RA, and smoking is identified, or the mechanism has been postulated. There is initial mucosal injury from environmental insult. Then there is localized innate immune response and expression of PAD and MPO leading to induction of oxidative stress. There is post-translational changes to proteins and peptides, formation of neoantigen, and these are the neoantigens citrulline, carbamyl P and MMA, and there is localized adaptive immune response, epitope spreading, somatic hypermutation, and autoimmune response in the context of genetic susceptibility with development of autoantibodies in the form of anti-citrullinated antibody, anti-carbamyl P antibodies, anti-MMA antibodies. These are all happening before the clinical expression of rheumatoid arthritis. So these are all can be identified if we have modulation in preclinical RA and transition to extramucosal sites including synovial tissues followed by RA onset. So this is the fifth stage before which already the happenings have happened. And there is components of bacteria as well. Prevotella copri, overexpansion of Prevotella copri in stool is seen in new onset and chronic RA. And higher prevalence of anti-Toxoplasma gondii IgG antibodies have been identified, whereas high anti-EBV and anti-parvovirus B19 IgG level, there is lower the risk of ACPA positive rheumatoid arthritis. There are antibodies, known rheumatoid factor anti-CCP, already established, causing disease activity alteration and structural damage. Whereas, and this is in relation to post-translational modification of proteins, citrulination and carbamylation, and citrulination is occurring through PAD enzyme, whereas carbamylation occurring through thiocyanates. And post-translational process mediated by cyanate, and the smoking renal failure enhances protein carbamylation, and the importance is this anti-CAR-P antibody has is a promising marker to predict joint damage disease activity in RA, especially in the situation where both rheumatoid factor and anti-CCP are negative. So we are gradually moving and gradually narrowing the spectrum of seronegative rheumatoid arthritis. The concept of genetic predisposition and second hit. As we were talking, there is environmental trigger in the susceptible host causing protein modification leading to antigen presentation in terms of tolerogenic dendritic cell. And when there is break of tolerance, there is first hit initiation, which lead to T cell activation and crosstalk up to B cell activation and release of autoantibodies. And there comes the initiation of pathogenic process, and these autoantibodies either in the form of rheumatoid factor anti-CCP or anti-carbamylated antibodies, leading to synovial inflammation, which causes either local pathology in the form of synovial hyperplasia and bone erosion, or systemic pathology in the form of pathogenesis, which is one of the very important extra-articular component in rheumatoid, metabolic aberration and CNS manifestations. But one should not forget that inflammation in rheumatoid arthritis starts not in the joint but beyond joint, epithelial surface. And the most important part is lung. Almost 75% persons with rheumatoid arthritis autoantibody positivity without joint symptoms, preclinical RA, shows HRCT documentable airway abnormality. And person with detectable autoantibodies in sputum, ratio of autoantibody to total immunoglobulin higher in sputum than serum. And so these autoantibodies were produced, sequestrated locally in lung tissues during preclinical phase of RA. And another area is oral cavity. Chronic periodontitis is very common. ACPA positive rheumatoid patients, high prevalence of periodontitis. Rheumatoid patients with periodontitis, higher serum concentration of autoantibodies with a more articular damage. And P. gingivalis can citrulate fibrinogen, and enolase peptide antigen, there is a role in RA pathogenesis documented. It can promote Th17 response, and RA patients have higher serum levels of anti-P. gingivalis antibody. And from our group in PG Hospital lab, we have documented that in reference to control rheumatoid population and periodontitis and another group RAPD, there is more lactobacillus, Neisseria and Clostridia, and there is reduction of Fusobacterium. So the bacterial milieu with a dysbiosis possibly is a very important predisposing initiative events in pathogenesis of RA. Now the preclinical phases of RA, characterized by inflammatory changes in synovium before the onset of clinical signs and symptoms, IgM rheumatoid factor and anti-CCP can be detected on an average 14 years before the onset of clinical rheumatoid arthritis, as is happening in anti-nuclear antibody in the setting of systemic lupus. And 20% of autoantibody positive subjects with arthralgia develop clinical signs symptoms of arthritis after a median follow-up of around 28 months. And this is the situation in a genetically susceptible host with environmental insult leading to autoantibody and without synovitis, ultimately through subclinical synovitis, through undifferentiated arthritis, there is development of overt rheumatoid arthritis. Now let's move to the very wonderful, exciting areas of imaging modalities, which is expanding in the setting of rheumatoid arthritis. There also we have contributed literature in the world scenario. Current status of ultrasound in rheumatoid arthritis, prediction of rheumatoid arthritis development in patients with clinically suspected arthralgia or undifferentiated arthritis have been identified. Positive synovial PDUS signal has identified as a risk factors to develop RA, can identify patients who have got a less chance of RA. Earlier detection of erosion and subclinical synovitis is possible. And there is important role for diagnosis of seronegative RA and role in predicting outcome. USG detected subclinical synovitis is predictor of structural damage and flare in RA patients. An ultrasound inflammation score, increased synovitis scores positively associated with current functional status in RA patient. And we recently come up last year, there is an association of angiogenic and inflammatory markers with PDUS vascularity grade and DAS28 CRP in early RA comparative analysis. we have documented that higher serum level of angiogenic and inflammatory marker like VEGF and 1 and 2 TNF-alpha noted in patients with moderate disease activity but with advanced PDUS vascularity, grade 3, in comparison to high disease activity group with less severe PDUS vascularity. That means that not the clinical disease activity index directly correlates with the underlying pathology, but it is the PDUS score which directly correlates with angiogenic denominator. So PDUS score probably would be a more sensitive marker or instrument to predict the outcome in a given patient of rheumatoid arthritis. That is the situation, the PDUS grade 2 and PDUS grade 3. So PDUS grade 3, but even in the setting of less activity, is more important than PDUS grade 2 with a high activity. So PDUS vascularity grading better reflects markers of angiogenesis and inflammation than composite disease activity index. We had our publication in subclinical atherosclerosis in early rheumatoid arthritis. Rheumatoid arthritis of clinical 1-year duration has been identified to have a denominator of atherosclerosis. Compared with the control, early rheumatoid arthritis patients have higher CIMT and lower FMD, denoting premature atherosclerosis. Our data suggests that early determination of FMD and CIMT may be useful tool to assess cardiovascular risk even in early RA patients. So what's to be done? So we continued our study and published in next year that if we start intervening them with a disease-modifying drug, can we change that one? Yes, of course. Effects of disease-modifying anti-rheumatic drugs on subclinical atherosclerosis and endothelial dysfunction, which has been detected in rheumatoid arthritis, 1-year follow-up. So even with the patients of 1-year disease duration, subclinical atherosclerosis are identified. And if we can intervene with combined disease-modifying drug, early intervention not only controls the disease but also retards the atherosclerotic progression. Next, we got funding from T-Board and we continued what is the outcome of T extract. The immunomodulatory activity of black tea extract and rheumatoid, which has come up in 2016 from our group. Black tea extract significantly downregulates ROS generation in treated cell, superoxide radical generation from activated neutrophil compared to black tea untreated sample. This has been done ex vivo, collecting the peripheral blood mononuclear cell, NO production from activated PBMC, and pro-inflammatory cytokine production from PBMC as compared to black tea untreated sample. Next, we had our publications as a platform in 2017 IRACON. This is the active compound of black tea. What is the outcome? In maintenance of apoptosis and autophagy in rheumatoid arthritis synovial fibroblast cell, we have cultured synovial fibroblast in our laboratory. In RA, the main impact of the disease falls on synovium, leading to angiogenesis, and which is the main events in initial pathogenesis. And we have documented that there is TF3 active compound significantly increase the level of apoptosis in RA synovial fibroblast cell, and there is significant reduction in the level of pro-inflammatory cytokine, reduction of angiogenic marker, autophagic marker were reduced after administration of TF3 in cultured fibroblast. So these are important issues which could be helpful in reference to supportive management as an add-on therapy. Let's look another area. What's the situation between short-term and sustained remission state in RA? What is the difference? And we have documented from our group that in respect to expression of the pro-inflammatory cytokines, the disease duration in remission, we have identified 2 groups of patients, 26 in one group, another 25. And disease duration, one was up to 6 months, another is beyond 1 year. So what's happening? So for the angiogenesis, so for the cytokine manipulations are concerned, we have documented that shorter disease duration, short term, both all IL-1B, VEGF, IL-17 and TNF-alpha, All markers were high in patients with rheumatoid arthritis who are in short-term disease remission. So patients who are in short-term remission are at risk for propagating the pathogenesis, and that should be given an enough importance and a close monitoring so for the therapeutic parts are concerned. So positive correlations were found between grayscale synovitis score and angiogenic marker in RA were in short-term remission. So not only the angiogenic markers which are high, but that could be correlated with ultrasound scoring. That's also directly correlated. So grayscale ultrasound score are very useful non-invasive modalities to predict the outcome of the disease process who are in remission, and that can be differentiated into two groups, short-term remission versus long-term remission. That's an ongoing work going on. And the last part is what's happening in the treatment part. New treatment strategies, JAK inhibitors. So it's a very exciting molecules. Talk of the day, one is tofacitinib. 3-year follow-up of tofacitinib has been documented. Treatment response is maintained even after discontinuation of methotrexate or steroid. This is very important, and it has been documented that all sectors, ACR 20, the tofacitinib has got an edge, even in comparison to TNF inhibitor, improvement in HAQ-DI score, the change in HAQ-DI is certainly better in tofacitinib group, and DAS28 ESR also better in comparison to TNF inhibitor. And baricitinib is another exciting molecule which has come up. Comparison to adalimumab, there is ACR 20 response is better, DAS28 response is better, HAQ-DI also better, and SDI also better. So these oral molecules and the radiographic progression in RA in comparison to TNF inhibitor certainly has got an edge over the available TNF molecules. Next, another and last part is IL-6 inhibition in RA. Tocilizumab has got a definite edge, and subcutaneous tocilizumab can improve the joint damage in RA. This come up in this month itself, and last month tocilizumab effects on serum lipid and adipokine level. So tocilizumab has protective role on the metabolic and cardiovascular burden associated with RA, and not only in RA itself but RA-ILD, they have come up with good literature support in reference to the effect of tocilizumab. So this is another very exciting molecule, because we know the traditional molecules are combination synthetic DRMATs followed by TNF inhibitor, and we are using as per convenience Ritax, who has got a rheumatoid factor positivity, but tocilizumab has got a definite edge. Head-to-head trial has shown that tocilizumab will be having a superior efficacy in comparison to the other available molecules. So now to summarize, smoking is the strongest environmental factor associated in RA. So that could be a very important primary preventive strategy in a susceptible family having RA, and regular dental checkup. Newer autoantibodies can redefine seronegative RA. Inflammation in RA may start in mucosal surface, as we know, in lung as well as in oral cavity and gut itself. Preclinical phase of RA is characterized by appearance of autoantibodies before suggestions of symptoms. USG is an emerging exciting modality for the management of RA. Evaluation, prediction of outcome and therapeutic response. Expression of cytokine and angiogenic mediators may be different among patients with short-term and sustained remission. Oral targeted therapy are promising in the management of RA, and anti-IL-6 therapy is a great potential therapeutic option in management of RA. Thank you. Thank you very much.
Thank you, Professor Alakendu Ghosh, for your nicely elaborated what is the new in rheumatoid arthritis, starting from its pathophysiology with a diagnostic modality, and also what is new in the treatment modalities. Really, we are grateful, and we have really enriched with your lecture. Thank you very much. As it is an oration, there is no question. So we conclude the session here.